Right, to move forward with our program, I'm going to handle the mic to Dr. Kim to introduce our next speaker.
Good afternoon, ladies and gentlemen. My name is Bogan Kim. I'm consultant radiation oncologist working in Sheikh Khalifa Specialty Hospital, Ras Al Khaimah in UAE. It's a great honor for me to participate in the 2026 AMSTRO meeting and to be here among the esteemed colleagues and friends. It's my pleasure, great pleasure, to introduce next speaker, Dr. Anoud Alnsour. Dr. Alnsour completed her radiation oncology training at the King Hussein Cancer Center in Jordan, followed by advanced fellowship training at the Royal Adelaide Hospital in Australia. She also completed the observership in Murphy Cancer Center, and she's working in the King Hussein Cancer Center in 2021. Her major interest is the breast cancer and thoracic cancer, and she's also having much interest in stereotactic radiation therapy. Thank you.
Assalamu alaikum and good evening. Thank you for the kind invitation. It's a great pleasure to be a part of this outstanding conference. Thank you for all the efforts. In the next 15 minutes, I will present the evolving role of SBRT in non-small cell lung cancer, starting with early stage disease, focusing in one of the hot topics nowadays, which is the role of SBRT in operable non-small cell lung cancer, surgery versus SBRT, who is the winner. Then also I will focus on the integration role between immunotherapy and SBRT. Is there a future? And I will touch on the role of SBRT beyond early stage, specifically in oligometastatic cases, and I will end up with the future direction and take-home messages. A quick introduction. As we know, lung cancer is one of the most common malignancies worldwide, with non-small cell lung cancer accounting for the majority of cases. And with increase in screening and advanced imaging, more cases are detected as an early stage disease, creating new opportunities for curative treatment. And SBRT, as a highly precise ablative treatment, has evolved from an alternative option to a key component in non-small cell lung cancer management across multiple clinical scenarios, as we are going to see. So I will start with early stage inoperable non-small cell lung cancer, as historically, these patients used to be treated with conventional radiation with very modest local control. And with time, since early 20s, phase 1 and phase 2 studies start to explore the safety and the role of SBRT in these patients. And we have many phase 2 trials, like the Timmerman, the RTOGs, the Bowman-Ital, the Japanese, the Netherlands. All of these trials, prospective phase 2 trials, showed or demonstrated high local control rate reaching up to 90%, with a favorable overall survival in these medically inoperable patients with multiple comorbidities. And importantly, these results were associated with low toxicity profile. But these trials were phase 2 trials. So at the end, we need a randomized phase 3 trial to confirm these findings. So we have the phase 3 randomized trial comparing head-to-head SBRT versus conventional radiation, and where they found that there was no difference in progression-free survival and overall survival between both arms, but better quality of life and less toxicity in the SBRT arm. After that, we have the Chazelle trial, phase 3 randomized trial published in Lancet back in 2019, which showed the SBRT has improved overall local control compared to conventional radiation, with a local failure 14% in the SBRT arm versus 30% in the conventional arm with significant p-value. Regarding the median overall survival, it was better with 5 years in the SBRT arm versus 3 years in the median overall survival in the conventional arm, with a minor increase in major toxicity. So all these trials together led to the standard of care, SBRT as the standard of care for medically inoperable patients, as this is, the SBRT is well tolerated, provided high local control, and improved the survival rate in these medically inoperable patients. And this takes us to the most important, or what the current hot topic nowadays, which is the role of SBRT for operable early stage non-small cell lung cancer. And as we know, surgery allows for pathological staging and guides adjuvant therapy when needed. However, it is invasive and carries operative risk. And on the other hand, SBRT is a non-invasive, well-tolerated outpatient procedure. And with improvement in SBRT outcomes over time, sparked the interest to involve SBRT in early stage operable patient as a less invasive treatment. And actually, a couple of trials tried to address this topic back, like the Japanese trial back in 2010, where they showed that SBRT is promising as an alternative to surgery for operable patient, and RTOG 0618, which showed that SBRT provides high rate of tumor control with infrequent need of salvage surgery, especially for peripherally located lesions. Then we have the STARS and Russell pooled analysis, which showed no difference in local regional control and even better overall survival in the SBRT arm with less toxicity. However, this pooled analysis has a lot of limitations and with limited number of patients. And this led to having the revised STARS trial back in 2021 as a propensity score matched analysis, which showed no difference in overall survival, but significantly higher local regional recurrence in the SBRT arm. And the revised STARS trial presented their 10-year updated outcome in the last ASTRO for this propensity score match analysis, with the primary endpoint of non-inferiority overall survival to SBRT versus surgery, with 80 patients in both arms. I would like to draw your attention here that the inclusion criteria was to include patients with less than 3 cm patients, and the median size was 1.8 cm in both arms, indicating favorable tumors. Also, I would like to draw your attention to the all patients who received SBRT underwent a baseline EBUS to make sure we are dealing with node-negative patients. Regarding the results, the 10-year overall survival in the SBRT arm was 69% versus 66% for the VATS lobectomy, the surgical arm, the hazard ratio of 0.7, which was below the non-inferiority margin of 1.9, as we can see from the chart. Also, for the 10-year lung cancer-specific survival, there was no difference between both arms. Moving to the recurrence-free survival, again, the 10-year recurrence-free survival, there was no difference between SBRT and the surgical arm. However, for the first instance of recurrence, either regional, local, or distant, number of patients was higher in the SBRT arm, with the total of 16 patients versus 8 patients in the surgical arm, although it was not statistically significant. And the patients who had regional or local recurrence, they received salvage treatment, even like salvage surgery, chemoradiation, or sometimes repeated SBRT if feasible. If we look at the grade 3 acute pulmonary or cardiovascular toxicity, the surgical arm, as expected, has higher toxicity compared to SBRT, with 50% versus 1% in the SBRT arm. However, the late toxicity, there was no significant difference. So they concluded for this 10-year outcome, revised STARS trial presented the last ASTRO, that there was no significant difference between the SBRT and the surgical arm for overall survival, cancer-specific survival, and recurrence-free survival. And they suggested and highly recommended a multidisciplinary evaluation for these patients for optimal treatment decision. But at the end of the day, this is a propensity score match analysis. And if we want to change the practice, we really need a phase 3 randomized trials to confirm these findings. And also, in my opinion, the revised STARS trial doesn't really reflect all the cases we are facing in our real practice. As the majority of cases, they included peripheral and central, but the majority, more than 60% was peripheral, were peripheral lesions, and the size of the lesion was less than 3 cm as part of inclusion criteria. And we are awaiting the result of ongoing clinical trial, which is the VALOR trial. It's a randomized phase 3 trial comparing head-to-head SBRT versus surgery with around 600 patients, and the estimated completion by September 2027. Also, we have a randomized phase 3 ongoing clinical trial, the StableMate, which is randomizing, again, head-to-head SBRT versus sublobar resection for operable but high-risk patients. And we are awaiting the results again because this will reflect will provide us with evidence for the future practice. So to wrap up this section, surgery or surgical resection is the standard of care for operable early stage disease so far, and SBRT can be as an alternative to a selected patient in operable early stage non-small cell. And let's move to the second hot topic in lung SBRT currently, which is integration between immunotherapy and SBRT in early stage. And the rationale for this combination is that distant recurrence, as we know, is the main pattern of failure after SBRT, impacting overall survival. And many patients receiving SBRT, they are poorly tolerating chemo, they're frail patients with multiple comorbidities, and systemic chemotherapy is not really the best option for them. But on the other hand, we have immunotherapy, which offers a promising approach with favorable toxicity and potential synergistic effect with the SBRT to improve the outcome and mainly the distant control. One of the main trials in discussing or addressing this topic is the iSaber trial from MD Anderson, published in Lancet 2023, where they randomized patients between SBRT versus SBRT plus nivolumab, 4 cycles of nivo, and they showed that event-free survival was significantly better with the immunotherapy arm compared to SBRT alone. And also, the local, regional, and distant recurrence were lower with the immunotherapy SBRT arm, with very modest increase in grade 3 toxicity comparing to SBRT alone. But again, this is a phase 2 trial, and we need to have a randomized phase 3 trial to confirm this finding, although this is like a promising, but we need phase 3 trial to confirm these findings. So we have the Keynote 867, the SWOG 1914, and the Pacific 4. I will go through each trial briefly to point out the important findings. So I will start with the Keynote 867, where they randomized the patient to SBRT versus SBRT with Pembro, 17 cycles of pembrolizumab, with the primary endpoint event-free survival. And unfortunately, the interim analysis data showed that there was no significant difference in event-free survival between SBRT and SBRT plus Pembro, and higher toxicity, grade 3 toxicity was higher with 40% versus 2% higher with the Pembro arm, and that trial was halted. And this brings us to the second trial, the SWOG 1914, with different protocol, where they randomized patients to SBRT alone versus SBRT plus induction, concurrent, and the consolidation atezolizumab with up to 8 cycles. And the primary endpoint was overall survival. But again, the result showed no difference. The interim analysis data showed no difference in overall survival and progression-free survival between both arms, and higher toxicity with 12% versus 2%. And again, the trial was halted, and the results were presented in ASCO last year. But we didn't lose the hope yet, as we have the Pacific 4 trial. And this trial randomized patient between SBRT alone versus SBRT with durvalumab with up to 2 years of durvalumab. And the primary endpoint is progression-free survival. This is the largest randomized phase 3 trial with around 650 patients and estimated to be completed in 2028. And we are also awaiting the results. So this slide just to highlight that we don't have yet clear data who are the best candidate to offer immunotherapy, what are the number of cycles of immunotherapy that needed, maybe the higher cycles or more cycles, the higher toxicities as we saw. And we don't know also the sequencing, the better sequencing of immunotherapy. Is it better to have induction, concurrent, or consolidation? But at the end of the day, overall, we don't have data to support immunotherapy in early stage non-small cell lung cancer. And again, we are waiting the result of Pacific 4 trial. Let's move on to the role of SBRT beyond early stage. I will focus on oligometastatic cases. And SBRT, the role of SBRT as a part of local consolidative therapy after frontline of systemic therapy for patient who doesn't have disease progression. And we have phase 2 trials like the Saber Comet with 20% of patients were having lung cancer. We have the Gomez trial, the Iyengar trial, and they showed improvement with progression-free survival. And some of them even showed improvement in overall survival with adding local consolidative therapy to these patients. Specifically mainly where was SBRT. But however, the number of patients were small, and that this trial doesn't really reflect the modern immunotherapy systemic therapy practice. So this provides the rationale to having the LU002, which is a randomized trial comparing maintenance systemic therapy versus local consolidative therapy, SBRT plus maintenance systemic therapy. And the vast majority of patients who were randomized received immunotherapy-based systemic therapy before randomization, which is reflecting the modern practice. And the primary endpoint for the phase 2 was progression-free survival. For phase 3 is the overall survival. And surprisingly, there was no improvement for the phase 2 analysis. There was no improvement in progression-free survival. The median progression-free survival was similar between both arms, with minimal increase in toxicity. But we don't have really all the data of this trial because it's only as a conference abstract, and the phase 3 overall survival results are awaited to determine any long-term survival benefits. What I would like to highlight from this slide that routine local consolidative therapy and SBRT may not be necessary in the immunotherapy era, and we need to individualize and multidisciplinary decision-making our decision before offering local consolidative therapy in these cases. And again, the patient selection and timing of the local consolidative therapy remain unresolved yet. We have a couple of ongoing clinical trials trying to address this topic, which is the SARON phase 3 trial with the chemo-based regimen with without radiation and SBRT to all metastatic sites. The North Star phase 2 trial for EGFR mutant non-small cell with zimertinib alone versus zimertinib followed by local consolidative therapy. And they presented, in the last ESMO, the abstract results, which showed improvement in the progression was lower with the osimertinib plus SBRT arm. We have also the ongoing phase 3 trial, which is Nivo plus ipilimumab with without radiation, and finally the immunosaber trial with immunocytokines alone versus with SBRT to all disease sites. And I will end up with looking ahead for future direction, as the future in SBRT is all about the precision for the right patient, right time, and right dose, guided by prospective clinical evidence. And we are still exploring the integration between immunotherapy and SBRT to see if there's a potential synergistic and even abscopal effects. And finally, biology-guided approaches like using circulating tumor DNA for risk stratification and personalized treatment decisions, especially for oligometastatic cases, is in the coming future. To wrap up, early stage non-small cell lung cancer SBRT is the standard of care. For operable patients, surgery is still the standard of care. However, SBRT could be a safe alternative in selected patients. We have no evidence to support immunotherapy in combining immunotherapy with SBRT in early stage. And for oligometastatic and oligoprogressive non-small cell, SBRT may be beneficial, but should be individualized. And overall, multidisciplinary decision-making and ongoing clinical trial results are essential to optimize our treatment strategies. Thank you for your attention, and happy to take any questions.
Thank you for your excellent presentation, Dr. Anoud. I'm receiving some requests due to the time constraint. About the questions, if you don't mind, we can using some kind of coffee break. But if there is someone who really want to make some question, is there anyone who having some question now? Okay.
Sir, I can't hear you very well. Do you have a mic? Ultracentral tumor. Okay, so if I understand your question well, for ultracentral tumor less than 2 cm from the main airway, what is the dose we use? Okay, so this is like beyond the scope of our talk and presentation. But again, we need to define if we are dealing with the central or ultracentral lesion. And if it's like from 2 cm from the airway, I will consider it within central lesion, and I will choose the constraint or the dose based to the organ at risk surrounding this lesion. However, if I couldn't meet the constraints, I will, for a critical structure or organ at risk, especially serial organ at risk, maybe I will do it more hypofractionated. Depends on the location of the lesion and the surrounding organ at risk.
Okay, thank you for your participation. We will move